more. We promise you a very interesting and interactive session, and we would like you, please, some housekeeping issues, to send your questions through the QA section. The registration for the subsequent workshop is completely different, and I'd urge you as well to do that after we finish this session. So without further ado, I'm just going to go ahead now and introduce the topic so that we can all have some time to think about what Professor Mogayzel is going to tell us about in the next hour. So we all know that patients with cystic fibrosis are entering a new era in terms of the care of cystic fibrosis. Patients with cystic fibrosis will definitely, patients with cystic fibrosis will definitely be living longer in the era of the CFTR modulators. There was an earlier polling there for some of our audience in a previous workshop, and the split was 50-50 in terms of people who are on modulators or not. But irrespective of this session here, despite the modulators, I think we have to, in the next few years, to remain laser focused on how we're going to do the basics right. So this is very important, irrespective of the modulator or not. Now, it is very important that when we talk about CF, to bring the historical background into it, and this takes us back to the old folklore adage, which says, "Woe to the child which when kissed on the forehead tastes salty, he's bewitched and soon will die." So up until recently, cystic fibrosis was considered to be a very lethal limiting condition. And since the advent in our better understanding about what is cystic fibrosis and genetics, things have changed, and now we talk about a life-shortening process, or a life that probably can be managed with these modulators. We all know that it is predominantly prevalent in the Caucasian population with different penetration. However, we also know that there are a lot of cases in different parts of the world which would oftentimes pass undiagnosed or under the rubble of other infections, chronic infection, bronchiectasis, etc. The basic pathology, as we all know, is the cystic fibrosis transmembrane conductance regulator, and the mutation in the CFTR gene, which codes for the chloride transport channel. This is the channel that sits at the surface of the cell, and when this is defective, there will be abnormal water and salt transport into these cells. This automatically will cause a buildup of mucus, and this mucus would be very sticky, will block the small airways and allow the bacteria, which we all breathe in the air, to become trapped in these airways, leading to airway inflammation, obstruction, and damage. So that's in a nutshell that we're talking about the pathology or the pathobiology of CF. We're all aware of different specific mutations in certain part of the Arab world and the Far East, and these are just some of the prevalent mutations as per the published literature. So we're speaking about the pathophysiology here with the CF gene defect, abnormal CFTR protein, defective ion transport, and delayed mucociliary clearance. So this would result into a mucus obstruction, infection, and subsequently inflammation. And we set ourselves into the vicious cycle of infection, obstruction, inflammation. And eventually, sadly, we will end up with this process in our lungs, something that we hope that we probably will see less and less of in the coming future with our increased awareness about the disease. I've just taken this from the cystic fibrosis patient registry annual data published recently.
I hate to interrupt you, but I don't think people are seeing your slides.
Okay, right. Thanks, Peter, for telling me. I might just go again and make sure that it is that. Might stop that and open it again. Can you see me sharing here, Peter?
No, not yet.
Okay. I'll try again. Is that better?
That's good.
Good, great. Thank you very
Just
much,
go ahead.
Peter.
There
Thank
you go.
you. Thank you very much. So we'll just very quickly, as I said, the CFTR gene defect, abnormal CFTR proteins, defective ion transport at the level of the cells, and that leads to depletion of the airway surface liquid layer with delayed mucociliary clearance, mucus becoming very sticky, and leads to trapping of the bugs, causing infection, inflammation, and that vicious cycle, which sadly ends up into end-stage lung disease. So we have a lot of basic stuff to interfere here with, primarily airway clearance with all the mucoactive medication that we could use, hypertonic saline, pulmozyme, etc. But then again, when we reach that bit of infection, the role of antibiotics becomes very important. So unfortunately, sadly, this is the picture that I was pointing to, whereby obstructed or very insipid mucus would lead to infection, inflammation, resulting in damage of the lungs, something that hopefully we'll see less and less of in the future. I've taken this slide from the cystic fibrosis registry data 2019, and it just gives us an idea of what was the median predicted survival back in the 80s, 90s, and what we are up to these days in the predicted 2015 to 2019, the predicted median survival is in the mid to high 40s. So I think, again, back to basics. How do we get those germs? Either by direct contact, indirect contact, and droplet spread. So prevention is better than cure. It is very important when we are structuring our CF clinics to ensure that we cohort those patients, segregate the patients in order to avoid any direct contact or indirect contact. We became very familiar during the COVID era with a droplet spread. And again, that's another big way of spreading infections. So what are the bugs that we will be touching on this afternoon or this morning, depending on where you are? There are common ones: the E. coli, the Staphylococcus, MSSA, MRSA, Pseudomonas, Steno, or Aspergillus, Stenotrophomonas multifida. There are other ones which we are beginning to know more and more about: Achromobacters, non-tuberculous mycobacteria, Cepacia, unfortunately, which will herald significant issues, decline in lung functions, etc., and many others. So again, taken from the CF registry annual data report, if you look back at the prevalence of the percentage of these individuals who acquire different bugs, the majority or the top of the league would be the Staph aureus, not surprisingly, Pseudomonas aeruginosa, and others. And if you look into different cohorting by age, you would see in the under twos, so there are many countries now are employing newborn screening, and in the under twos, the most prevalent one to start with would be our friend, the MSSA. And then with time there, as we could see, the Pseudomonas aeruginosa will take over. So I think my message here is, whilst we will be focusing on antibiotics, etc., it's very important to get the basics right. Prevention is always better than cure. Maximize airway clearance, and then we'll get onto our antimicrobials, where we'll have to have or develop a smart approach, and we have to be laser focused in terms of our selection, because we don't want any multi-drug resistant organisms. So with this prelude, I am delighted, and it's my pleasure to introduce the next speaker, Professor Peter Mogayzel from Baltimore, who's going to take over this and share with us some scenarios, and we'll take it from there. Peter, it's all yours. Thank you.
Well, thank you. I appreciate the opportunity to talk and talk to you about, as the title says, some common things we deal with day to day, and some more unusual organisms which can oftentimes be more challenging. I'm just going to share my slides here. So where we're going to start is just where Basil left off in the last talk. What's common? Well, this is the data cohorted by age. Staph in this green line is the most common organism that one sees throughout most of childhood. Pseudomonas in the blue becomes more prevalent as one gets older. But you can see that even in younger children, this blue line is present. So that 20 or 30% of kids, even early childhood, will grow Pseudomonas. H. flu is in this brown line, which is more of an organism seen in younger children. And then the emergence of MRSA in this red line as you get older. And there are a number of other gram-negatives that were alluded to, which are at low levels in the population, but can cause significant problems. So I'm going to talk to you a little bit about Pseudomonas, some about MRSA, touch on some other things that aren't in this picture, but are clearly part of the microbiome, non-tuberculous mycobacterium and fungus, and talk a little bit about the end about the microbiome and maybe where modulators are going to take us. So, I'm sorry, I managed to, there we go. So the picture I just showed you is individual bacteria, but in fact, bacteria don't live in the lung in isolation. This graph illustrates how certain prominent organisms are combined. So when we look at cultures, again, across the age groups, what cultures do you actually find? In many younger children, you don't get any infections. That doesn't mean the lungs are completely sterile, but it means that in throat cultures, which are typically performed in these younger age groups, we're not finding any pathogens. There's a lot of staph here in blue, but there's also staph combined with Pseudomonas in this red, and Pseudomonas alone, which becomes more prominent as you get older, in the green. There are other combinations here of organisms. This just gives you a flavor for the idea that there's diversity in the airways and not just a single organism. We think about treating Pseudomonas or staph, but that's really a simplistic way of looking at the airway microbiology. And I just want you to keep that in mind when we're discussing these individual therapies. We spend a lot of time focusing on Pseudomonas because of data like this. This is data that's actually, almost 20 years old now, from Sweden, looking at patients with Pseudomonas, either pancreatic sufficient patients here or pancreatic insufficient patients here. And you can see if you have Pseudomonas, your lung function decline is faster than if you don't have Pseudomonas. And that's true if you're pancreatic sufficient, who typically have milder disease, or if you're pancreatic insufficient, where you have a slower decline without Pseudomonas than with Pseudomonas. So we know that Pseudomonas leads to this faster decline in lung function, more exacerbations, earlier mortality. I do want to point out one thing about this graph, and I use this graph, I like this graph because it shows you something else. It shows you the trend that's changed over time in therapy. This is starting at age 5 when kids can reliably do pulmonary function testing. And you notice that pancreatic insufficient people are starting with an FEV1 of 80% predicted. And that really is a feature of the times. It's a feature of the fact that people were sicker 20 and 30 years ago than they are now. That's partly because of newborn screening. It's partly because of more aggressive approach to nutrition. It's partly because we are trying to do Pseudomonas eradication and realize getting rid of organisms early is beneficial. So what I would expect today is a patient starting, when they start doing pulmonary function testing, to be at 100%. That's really the goal. And it drives, it also points out that what we think about as far as therapy really is driven by your expectations. If your expectation is someone's lung function is going to be 100%, you're going to treat them differently than if their lung function was 80%, and that's okay. Same thing is true for bacteria. If it's okay for them to have Pseudomonas, which is the way I was trained, it's just one of those things that happens, then you don't worry about eradication or other therapies when you first find Pseudomonas. So that's kind of where we're going to start. What happens in the newborn lung? Well, you're born with normal lungs. There is a defense mechanism that's abnormal, in abnormal mucociliary clearance and other factors. There's intermittent infection with Pseudomonas. We think that eradication therapy can be beneficial here. Eventually, the bacteria change and you end up with persistent infection. And here we do suppressive chronic therapy. So let's start with an initial case. An 18-month-old girl, F508del homozygous, has had oropharyngeal culture that at a routine visit grows Pseudomonas aeruginosa. The question is, what would you do next? Oh, I should have mentioned there are polls in here. So I hope that you'll all participate and vote on what you think you would do in these scenarios. So Mohammed, can you put up the first poll? So what would you do? Would you repeat the culture? Would you not do any therapy because the patient's asymptomatic? Would you treat with 28 days of tobramycin or maybe tobramycin and ciprofloxacin? Would you do, which is what we tend to do in the United States, you know, around the world, colistin is used widely. So would you do 3 months of colistin or 3 months of colistin with ciprofloxacin? Or would you say we really want to make sure we get rid of this and we'll treat with IV antibiotics? I'll just give you a couple of more seconds here to choose, and then we'll see what the results are. I'll vote too. How about that? All right, Mohammed, what are our results? Okay, so it's a mixture here. Some people would just check to see if it's there. Other people, it's not a problem, don't worry about it. There's sort of half the people would do tobramycin either with or without ciprofloxacin, and a few people would do other more intensive therapies. So what do we know? We know that an eradication therapy is effective. And actually, there are several antibiotic approaches that have been shown to be effective. There have been some big studies, though, that have looked specifically at certain therapies. What we know is it doesn't seem to be necessary to add ciprofloxacin. So if you're using 28 days of therapy with tobramycin, we know that's an effective therapy. Is that enough? There's a big study, the EPIC trial, that looked at treating with ciprofloxacin in addition to the tobramycin, and it didn't seem to add additional benefit to use ciprofloxacin in addition to tobramycin. It also didn't seem to be necessary to go longer than 28 days. The ELITE trial looked at 56 versus 28 days, and it didn't seem that there was a lot of value to that. There also showed that there wasn't value to prophylactic antibiotics. So in other words, giving people tobramycin once every 3 months to prevent acquisition of Pseudomonas did not seem to be valuable. I chaired the Pseudomonas aeruginosa eradication guidelines many years ago, which really showed that if you found a culture, you should treat it. That was the recommendation, not necessarily to worry about symptoms if they're not symptomatic, or to wait for repeat cultures. Now, obviously, there are some people when you use this approach that are going to have transient infections, or you're going to get a culture that's in the upper airway but not in the lower airway. But the benefit of doing therapy without additional invasive testing, because one could envision doing bronchoscopy to confirm the diagnosis, seemed to be the thing that would have the most benefit with the least risk. So a high certainty of benefit, it's substantial, like an A recommendation. And we recommended tobramycin once a day for 28 days. Part of this was because this was the simplest regimen to do, and with the least amount of burden and the least amount of toxicity. It's not that other regimens don't work. So doing 3 months of colistin, doing aztreonam, doing other things are effective. It's this was the simplest approach which we thought was effective. This is just a real world data from Johns Hopkins that we put together a little while ago. We had about an 85% clearance rate of Pseudomonas. And then we looked at how soon did it come back again. So this is a Kaplan-Meier graph. These are months on the x-axis versus the likelihood that the Pseudomonas would return. And there are three graphs. There's the blue is just tobramycin alone. The red is tobramycin with ciprofloxacin. And then the black are people that got IV antibiotics. And you can see the likelihood of reculturing Pseudomonas was about the same in all three groups. You don't really need a lot of statistics to see that. We know also, though, that failure is not good. When you have a failure to eradicate, people have worse outcomes. The EPIC trial followed people for about 5 years. Most people got eradication therapy, but about half eventually acquired Pseudomonas. And what you saw is when there was, despite widespread eradication therapy, if you didn't eradicate it, there was an increase in exacerbations, you were more likely to have physical findings, you were more likely to culture other organisms. There wasn't a big impact on lung function or nutrition in this short outcome, but we know in the long term it will have an impact. And the factors that were associated with eradication were related to the organism, were change in phenotype to a mucoid phenotype, and then creating more of a biofilm, something that's going to allow the bacteria to stay in place and not get treated effectively by the antibiotics. So the question is then, if we're not clearing everybody, should we do something different? You know, I said, well, you could do IV antibiotics, but really, should we do that, and would that be helpful? The Torpedo study looked at that. This was just published in Lancet Respiratory Medicine this year. They looked at 3 months of inhaled colistin and then either adding ciprofloxacin or doing intravenous antibiotics with ceftazidime and tobramycin. And they found there was really no difference in the probability of being Pseudomonas free 15 months later. The oral antibiotic is shown in red, the IV is shown in blue. So in fact, if it's not statistically significant, you're actually better off with the oral than the IV. The other question is, could you add to an adjunct therapy? The Optimize trial looked at adding azithromycin. As I think people know, azithromycin has been shown to decrease the rates of exacerbations in people that are chronically colonized with Pseudomonas, and also people that aren't colonized with Pseudomonas. So they looked at, if you gave people initial eradication therapy and then followed it by 18 months of azithromycin, would that prevent recurrence of the Pseudomonas? And what they found was there really was no impact on microbiologic outcomes, meaning that people were just as likely to reculture Pseudomonas or clear the Pseudomonas with or without the azithromycin. But the people on azithromycin did a 44% reduction in exacerbations, and that data is shown here. So the likelihood of having an exacerbation in the subsequent 78 weeks was less likely if you're on azithromycin compared to the placebo. This goes along with the idea that azithromycin is working as an anti-inflammatory drug and may not be impacting the infection probability to any great extent. There are concerns with azithromycins that have been raised recently, though, with the idea that azithromycin may have an impact on the effectiveness of tobramycin. This is data from a clinical trial for Caistin, for Strianam. And what they looked at is what's the change in lung function for those people treated with tobramycin during their month of therapy, whether you were on azithromycin or not. So if you were not on azithromycin, your lung function went up. If you were on azithromycin, it didn't really change. And this is the absolute and the relative change. There didn't seem to be an effect of azithromycin on Strianam, on Caistin. This is thought to be related to increased efflux pumps that are induced by the azithromycin, so that you actually pump more of the tobramycin out of the cell and make the Pseudomonas more resistant. The TEACH trial looked at this in the chronic setting and didn't find a striking difference between the two, but that data is yet to be published. But there is registry data looking at azithromycin therapy and exacerbation. So if you're getting treated with intravenous antibiotics for an exacerbation, did it being on azithromycin actually make the outcome worse? So did azithromycin impact the outcomes? So they looked at over 2,000 children, 5,000 exacerbations, about half were getting azithromycin during their hospitalization or IV therapy. And what they found is the ones getting azithromycin were likely to have a lower improvement in FEV1, so their FEV1 did not go up as high. They had a lower odds of returning to their baseline, and they had a shorter time to the next exacerbation. So it seems as though azithromycin may be impacting the effectiveness of tobramycin and maybe should be used with a little bit more caution in those people that you're treating with tobramycin, either chronically or acutely. This is still a very controversial area, so I don't have the absolute answer for you, but I can tell you that we're very early adopters of azithromycin at Hopkins, and everybody was on it, and now we're really pulling back from that, looking at whether or not people are using tobramycin as a maintenance therapy. So I have another poll. What happens if the eradication fails? So you did your first eradication, you gave them some tobramycin just alone, because that's what we recommended. What would you do next? Well, you could do it again. You could give them tobramycin and add some azithromycin, some ciprofloxacin. You could try another inhaled antibiotic. You could do Colistin, you could do Caistin. You could do another inhaled antibiotic with oral antibiotics. You could admit them to the hospital and do IV antibiotics, or you could say, they're colonized. We're just going to do chronic inhaled therapy. I know, obviously this is simplified. There are lots of other possibilities here, but for to get a sense of what people would do, I just wanted to give you a couple of minutes or a couple of seconds to answer this question, and then we'll see what the audience thinks. Mohammed, what does that look like? Okay, many people, if you'd done inhaled tobramycin, you would maybe repeat it or add some ciprofloxacin. A large person would admit people to the hospital, about a third, or start a chronic therapy. So which of these answers is right? Oops, I gotta get rid of this, hang on. Well, there's really no data to say what you should do next. I think that this is something that really needs to be studied, and it's unclear. It's a challenging kind of study to put together. I can tell you what we do. Our tendency is if you've failed one course of inhaled antibiotic, we tend to treat you with another course of a different inhaled antibiotic plus ciprofloxacin. If you fail that second one, then we do intravenous antibiotics. But to be honest with you, if you fail the inhaled antibiotics, our rate of clearance with intravenous antibiotics at that point is very low. So either we missed an opportunity by not doing it earlier, or they're chronically colonized and they're just chronically colonized, and you need to start chronic therapy. So I don't have the answer for you as to exactly what the best approach is here, but I think being aggressive, as I said, is still the approach I would recommend. And it does need to be personalized or tailored with the family. In many cases, families don't want to do IV antibiotics. They'd rather just do chronic therapy. And we also don't know how modulators are going to impact this and modulate and impact the idea that you can actually have greater improvement or greater likelihood of eradication. So please put in your questions as we go along here. We'll be answering things at the end. I'm sure there'll be some time, and we'll go from there. Let me just mention, I think that you need to know that chronic antibiotic use is changing. So this is the original TOBI trial. 1 month on, 1 month off, 10% improvement or 12% with using tobramycin. Placebo doesn't really change. This was the standard way of giving antibiotics. As more antibiotics in the United States have become available, the patterns have changed. This is the use of the antibiotics that were available in the United States in 2009. So an aminoglycoside, tobramycin primarily, was used in 95% of people with Pseudomonas. This is data from the CF registry. About 16% were using Colistin, a few percent were using Aztreonam. Aztreonam became approved in the United States. They captured 40% of the market. But you notice there's a lot of overlap here. There are people alternating one and the other. As we move along, alternating some therapy has become more prevalent, especially in the adult population where the resistance is becoming higher. So with these changes, you can see that trends have changed. And Basil showed you this earlier. This is over time now. So 1993 to 2019, there is less Pseudomonas. This is, people are healthier, we're being more aggressive with eradication, but there's more staph in the population. And this increase in staph in the population really corresponds with this increase in this yellow line here, which is an increase in MRSA. And that's true in the general population, not just in cystic fibrosis, but it really does emphasize that MRSA is much more likely to be a lifelong colonizing organism than Staph aureus. And MRSA is probably not good for you. This is data that we put together at Hopkins some time ago from the CF registry, looking at people that were MRSA positive here versus MRSA negative. This is survival now, and this is age on the x-axis. So clearly, it's better not to have MRSA. You're going to live longer than if you do have MRSA. Now, this is, correlation data. It's not clear that the MRSA was the reason that people didn't live as long. But if you look at this data in a Gestalt kind of way, it's better not to have MRSA than to have it. So can you do a similar kind of approach for eradication in MRSA? There is a thought that you can. This is data from Marianne Muhlenbach at UNC, and she did a study following research that was done in the UK showing that you could have eradication when you did aggressive antibiotic therapy as well as topical and environmental cleaning. So they did Bactrim, trimethoprim sulfamethoxazole for a month, plus chlorhexidine mouthwashes and nasal mupirocin. Then they did body washes, environmental contamination. And what they showed was that if you did your therapy and then looked at 28 days, you were much more likely to eradicate. So this is patients that were negative at 28 days. If you did all this therapy compared to those that just did observation. However, over time, if you looked out, although you had a lot more, you had an improvement in FEV1 as well, though this is not statistically significant. If you look out over time, a number of these patients that you cleared from MRSA, it would recur. And the other issue is there is a fair amount of MRSA that we feel is transient. So it's there on one culture and not on the next. So the question is then, if with this kind of data and knowing what we know, is it appropriate to do MRSA eradication? So your next poll. Have I got the, is this in your way? I'm sorry, if I get the, you look at the questions and answers, I can't tell what you're saying there. Would you do sulfamethoxazole Bactrim, maybe with rifampin? Would you do Bactrim or rifampin, with some environmental cleaning? Would you do some other oral antibiotics? Would you do IV intravenous antibiotics? Would you not do eradication therapy because there's patients doing well? Same scenario, patients doing well. Or we just don't have enough information about that. So Basil, what is it? Mohammed, what does that look like? Okay, so about half the people would do, well, most people would do something. Let me start with that. Only about 20% would leave it alone. But most people would do Bactrim with maybe with rifampin and try to do cleaning, and about half of the people that would treat would do something else. This again, the data is out on this, on exactly what the best approach is. Our experience, this is actually, when we pulled this data together, I actually thought it was better than, it turned out to be better than I thought it would be. We did, majority we did with Bactrim, about 83%. Then we started adding rifampin, so about 10% of people got rifampin, just 30 people here, so it's not huge numbers. It did turn out that if you did something that you were much more likely to have a negative culture. And the eradication rate was about 56% at a mean of 86 days. So there is some suggestion that you can eradicate, do eradication therapy. I don't have the data here. We did do a study of inhaled vancomycin and Bactrim for people with established mRNA colonization, and that had no impact. So eradication therapy may be like Pseudomonas therapy, something you have to do early and not necessarily for people that have chronic infection. There are a lot of questions that remain. Do people adhere to this cleaning and other environmental and topical things which you need to do in addition to antibiotics? Are there risks for resistance? Is there really a long-term benefit to eradication? You know, should you do it if there isn't that benefit that's obvious? You know, is there really this intermittent positivity? And is that going to be something that's going to confound the results moving forward? And then inhaled vancomycin is coming. Is there an opportunity here to say, you know, we could do something with inhaled vancomycin early, and that may get you the same place as inhaled tobramycin did. So before I move on, because we're going to change topic here, I did want to answer a question that was in the chat about the torpedo study. I don't have a good explanation why the eradication rates were lower in the torpedo study than some of the other ones that you see, some of the other data that was that's out there. But we'll answer the rest of the questions at the end because I don't want to shortchange anyone. Uh-oh, this is not a good sign. Is that PowerPoint not responding? Okay, here we go.
So Peter, there was a question about, do I have to eradicate any organism even if the child is asymptomatic?
You know, I don't think so. The only organisms that we eradicate are Pseudomonas and MRSA, and we'll talk about MTM in a minute. There was a time where we would try to treat any gram negatives. It's interesting that in babies, they grow all sorts of gram negatives. A Chromobacter, a lot of lactose fermenting gram negatives, and they'll grow them transiently on cultures. And I assume that's because of breast and bottle feeding and putting things in their hands in their mouths and things. But we were very aggressive about treating them. And then we really felt that it wasn't clearly having a benefit because there was all this transient infection. Other parts of the world, though, are much more interested in treating staph when they see it. Our practice is not to treat methicillin-sensitive staph when we find it, but that is something that is treated in other parts of the world.
And the use, since we're global in this, the use of other aminoglycosides such as inhaled amikacin and IV gent in place of Tobra because of poor availability in different parts of the world. What's your take on that?
You certainly can do that. In our practice, Pseudomonas is uniformly resistant to gentamicin. However, in an inhaled version, it may be adequate because you're getting such high concentrations in the lung. Amikacin is also a substitute for tobramycin. You could use one of those others. Tobramycin is just more readily available in the United States.
Sure.
Well, let me change gears here and talk about non-tuberculous mycobacterium. So here's one more poll for you. 16-year-old F508 del homozygous, very healthy, 107% FEV1, typically grows staph and occasionally Pseudomonas, is being treated for this, has a history of ABPA, but that not currently being treated for this. He had a routine culture and then a repeat culture that grew Mycobacterium abscessus. So the first thing you need to do in this setting is determine, is the Mycobacterium playing a role in their, for them. So the next step is really to get a CT scan. There we go. So here's a CT scan. And what you can see here is there's just an area of bronchiectasis, not huge area, but one here and one there that wasn't there on the last scan, which was done a couple of years ago. So the question is, in this healthy young man with some changes that could be related to NTM, could be related to just progression of CF disease, what would you do? Well, he's grown abscessus, so the therapy is an arduous one. Would you do intravenous amikacin and imipenem and some oral antibiotics? Would you say, well, he's actually healthy, let's skip this IV part and let's just do inhaled amikacin and oral antibiotics? Would you say, let's skip that, let's just do oral antibiotics? Or would you say, hey, you know, he's actually doing quite well, let's not treat him and just observe and see if this is actually a pathogen that we need to do anything about? I'll give you a minute to think about that. It's This is a challenging situation. So, Mohammed, where do we end up with this one? Okay, so more than half would treat. Actually, a quarter of people would not just watch him because he's doing well. 3/4 of people would treat him in some way. Most people with the standard kind of IV amikacin independent oral antibiotic, but some because he's doing well, maybe skipping the IV part. So NTM is becoming more prevalent. This is data of prevalence in the United States from the CF registry. About 70 or 80% of people actually got culture, so not everybody got a culture. And it's about 10 to 15% of patients when you get to be adult. Most people grow MAC, but a large proportion grow abscessus, and then there's a smattering of other NTMs. I guess TB is not an NTM, it's TB. And this proportion has changed over time. There used to be more MAC and less abscessus. It is geographic, so this is prevalence of mycobacterium in the United States. Black is more, white is less. So you can see it does have a geographic distribution. There's also a geographic distribution of which is the most common. So in these black states, almost everything is abscessus. And in these white states or gray states, very little is abscessus. And nobody really has a great explanation for why there is this geography. It may be related to humidity and water pressure, may be related to common sites that nobody has a really good explanation for this. Around the world, there are differences. These are studies from North America. Black is abscessus, gray is Mycobacterium avium, and then white are other Mycobacterium. And you can see around the world, these studies from Europe, these are studies from Israel, there is a different proportion of which Mycobacterium is present. We know that NTM is associated with other factors, not so much, a little bit with age, but more with Pseudomonas infection and ABPA. You're more likely to have abscessus. Of course, age does confound this a little bit, but this is data from the UK registry. In that over time, your lungs become more damaged. And there are a lot of environmental sources for NTM. So peat-rich soils, things around water, so drainage, streams, rivers, drinking waters can be, and water systems can be sites for NTM. Refrigerator ice. I get asked about shower heads all the time because there's data showing that NTM can be in shower heads. Hot tubs are always a no-no. And then biofilms that are associated with any of these. And we know that NTM has a decline, leads to decline in lung function. So this is, decline in lung functions on this side, improvement on this side. So over time, in this big cohort that was followed for 30 years, NTM had the worst decline in lung function, followed by Cepacia, which we think of as being so horrible, followed by alkyligenes and Pseudomonas, and then clearing of abscessus, if you can do that, led to improvement. Mycobacterium avium didn't have a huge impact on change in lung function. And that goes along with our, sort of anecdotal evidence. People with abscessus tend to have more problems than people that are associated with Mycobacterium avium. There are consensus guidelines that are unified between Europe and the United States. They have a diagnostic criteria where you need to have some changes on CT scan and excluding other diagnoses. These are things that CT changes happen in CF. So you have to exclude that it's just CF or that it's ABPA or some other things. You have to have positive cultures from expectorated samples or bronchoalveolar lavage or some tissue that evidence of infection. And then you have to decide on a treatment. So these are just some schematic view of what you would do. So if you have positive cultures in these black, the idea would be that you, for MAC, from Mycobacterium avium, you would treat with oral antibiotics, typically azithromycin, rifampin, ethambutol, until the cultures became negative, and then you would treat them for usually a year afterwards. There is now salvage therapy available or recommended in the form of intravenous inhaled amikacin or Eradicate in the United States for those people that don't clear. And so for Mycobacterium abscessus, there's an initiation phase recommended with intravenous antibiotics usually including amikacin, as well as azithromycin, and then you transition this when you do 2 or 3 months of this to inhale the amikacin down here, and then a combination of oral antibiotics depending on culture results and sensitivities. Clofazimine, minocycline, and moxifloxacin are listed here. Linezolid is oftentimes used, and doxycycline is oftentimes used. And then you would do this again till the cultures remain negative for a year or longer. There are some additional therapies that are used when people either don't clear or relapse. Bedaquiline is an oral antibiotic that's been around for a long time and has been shown to be effective as salvage therapy. Meropenem vaborbactam and imipenem relebactam in combination with amoxicillin, these are beta-lactamase inhibitors. And these ones in particular, not clavulanic acid or some of the other ones that are out there, have been shown to increase the susceptibility of non-tuberculous mycobacterium to these intravenous antibiotics, but also to other beta-lactams. It's actually amoxicillin will work with relebactam. You just can't get relebactam by itself, so you have to use the combination drug. And then things that are under investigation. Gallium has been studied for Pseudomonas. It is a drug that replaces iron and therefore kills bacteria that require iron. Nitric oxide enhances the killing effect of macrophages. This is how macrophages kill NTM. GM-CSF creates more macrophages, which is what kill non-tuberculous mycobacterium. And bacteriophages, there's a lot of interest in these as drugs that will, or as viruses that will kill resistant organisms, NTM and Pseudomonas and others. So NTM is complicated. NTM is one that's very controversial. We tend to be aggressive about treating, especially abscessus, and we've had, I think, reasonable success with clearance or maintaining lung function over time. Fungus is something else that is also controversial about whether it causes problems or not. This is data we published a decade ago now, so it goes back to 1997, and you can see there was very little fungus in our cultures. These are clinical cultures at Hopkins, but by the time we got to 2007, there was about 30% of the patients were growing some sort of fungus, typically Candida or Aspergillus. More fungus was associated with chronic antibiotic use, both oral and inhaled. And I think this has even more become more prominent. This is data from the German CF registry published this year. And you can see in the gray are Candida albicans, which is found in 60% of adult patients. Other Candida scedosporum in the blue, which we don't see as much of here in the United States as I think they're saying. Oh, I'm sorry, Aspergillus is in the blue. That makes more sense. Other Candida in the yellow, and then some other fungi down here, including scedosporum, which is this blue line. We focus a lot on Aspergillus because Aspergillus not only causes infection, but causes ABPA. The data from the registry that they put in this paper showed if you had chronic Pseudomonas infection, having Aspergillus didn't make that much difference. So this is no Aspergillus, this is Aspergillus. If you didn't have chronic Pseudomonas, though, having Aspergillus did make a difference. And this is what we find in younger children. If we do bronchoscopy, we oftentimes find Aspergillus growing. And the challenge is this a pathogen and should we treat it? Because you don't find it if you're doing just oropharyngeal culture, so you can find it in sputum. So when you're thinking about Aspergillus in particular, you have to think about, is it an infection or is it leading to ABPA? So ABPA is an IgE-mediated allergic syndrome. We screen for people after age 6. If their total IgE is greater than 500, then we look for IgE-mediated response, meaning that we're going to do a skin test or IgE-specific Aspergillus antibody. If it's less than 500, it doesn't mean they can't have ABPA. It means you have to still look for it if there are concerns. And then what do you need? Well, you need to have clinical deterioration and radiographic changes. Same thing as NTM, right? There has to be a problem. You have to really diagnose it as being a problem and not just have it be CF. High IgE, evidence of IgE-mediated response, and then something that helps you are precipitants to say there's been some exposure or chest X-ray changes or CT changes. The therapy for ABPA is oral steroids. It's oral steroids. I tell the fellows on the board the therapy is oral steroids. There are other adjunct therapies. Antifungals can be effective in some cases, we think, because it decreases the immunogenic burden. There are reports of Xolair, omalizumab being effective in people whose Ig is not terribly high. And pulse steroids has been described as being effective as well. But if you don't think they have ABPA, if you think there's actually an infection, then antifungal therapy, either with oral antifungals, voriconazole, and itraconazole, the two we typically use. Posaconazole is also available. And then there are IV ones for people that really have invasive disease, or not invasive disease, really bad disease. In my mind, the Aspergillus leads to more dense, thick plugs. So in people that when we do bronchoscopy, people that grow Aspergillus where it's really causing an infection, the plugs are much more dense, much more hard to get out. They oftentimes are associated with areas of atelectasis that you can see on a CT scan. So our approach to fungi is if you treat the bacterial things and things are still an issue and the fungi is there and they don't have ABPA, so their Ig is not elevated, that we'll treat with an antifungal at least for a month, usually for a more prolonged course of 3 to 6 months, to see if that doesn't improve the situation. But as I mentioned earlier, it's not just one organism. There's a whole milieu in the airways. This is a graph of different children, and just to take away from this, all these different colors are different bacteria. So this first one, pink, this green is Pseudomonas, but there's a whole bunch of other stuff. When you culture, all you're going to get is Pseudomonas. Same thing here. This is staph. All you're going to get is staph. So the milieu is more than just the one bacteria. And we know the microbiome changes. So it changes with age, it changes with antibiotics, and it changes with the population. So we know that there's more diversity, or less diversity when you're born. You get more diversity as you get older, you get less diversity as you start having single organisms that are predominant. We think that having more diversity is better, and a healthier lung has more diversity, but we don't really know how to encourage this or how to interpret this. Okay. And then finally, what's going to happen with modulators? This is data from ivacaftor, looking at various infections from the UK registry. So this is where ivacaftor became approved in 2013. And you can see this is cross-sectional data now, but you can see the people that are not on ivacaftor, continue to have these infections. This is Pseudomonas, but the people on ivacaftor have less. Staph doesn't really seem to be impacted to a great extent. Sapacea doesn't seem to be impacted. Aspergillus does, though. There's less Aspergillus over time with ivacaftor. So we think this is also data that's comparable to what we saw in the GOLD trial, looking at people before and after therapy. So I think that there's an opportunity here to have less infection, less chronic infection, and presumably prevent infection over time with the use of modulators, especially if you're starting them earlier in life. So some final thoughts. Pseudomonas, NTM, fungal MRSA all have significant impact. Pseudomonas eradication strategies do reduce the risk of exacerbations and can be effective. There's questions about MRSA. NTM is something that requires very intensive strategy, but I think is worth doing if you're sure that the NTM is playing an impact on people's lung function. And then novel detection strategies may be coming to the clinic. It's unclear whether RNA-based non-culture therapies or testing will be valuable and how we can use it. And then our approach may be changing in the future as modulators become more widely available. But as Basil said at the beginning, people are still going to have infections. It's not something that we're going to wipe out infection in CF by starting everybody on modulators. So thank you very much for time. I think we have a few minutes left for some questions. And I appreciate, again, the organizers inviting me to to speak.
Peter, thank you very much for an excellent talk. I think you've revamped our minds with all this data, which is great. A couple of questions there. I'll just take one very quickly. I suppose we'll have to raise this talking from this side of the Atlantic. Flucloxacillin prophylaxis. What's your take on it?
So we do not routinely do staph prophylaxis. I know it's done routinely in Europe and the Middle East. The data that we have in the United States from many years ago with cephalexin shows that there's more likely to be Pseudomonas when you do staph suppression, so we don't routinely do it. And the new data about microbiome saying more antibiotics leads to less diversity also kind of reinforces doing less is probably better over time.
So we're conscious, obviously, of the cephalexin being more sort of a wider spectrum anti-MSSA, whereas flucloxacillin is a narrow spectrum, and obviously the data is always there and the debate is always there. But if you mentioned something, if I have a baby identified through newborn screening and identify heavy growth, now I know heavy is different, +3, when you get a report antibiogram +3 staph aureus, and the baby is doing well, would you sit tight or treat?
Our practice is to sit tight. So if you have staph, no matter how much staph you have, we would not treat it unless the baby is symptomatic. That's our practice. Other places might do, other places in the United States may do practice differently. If you were to grow MRSA, we would treat that. And it's challenging because the first baby born in the first baby diagnosed by newborn screening in the state of Maryland came to clinic, and her first culture grew MRSA. And she was colonized, she's been colonized with MRSA ever since. So our understanding of colonization is challenging. But yes, we leave the staph alone.
Good. Another question, obviously being global and in different parts of the Middle East, there's difficulty with inhaled tobramycin, colamycin availability. Is there any data to support inhaled or nebulized gentamicin therapy?
Yeah, I think we mentioned this one earlier. The gentamicin can be effective. We don't use it in the United States, or I don't use it because we tend to have bacteria that are resistant to gentamicin. Even with resistance, if you're doing inhaled gentamicin, it may be effective. And there is data with eradication protocols that have used gentamicin in the past. Amikacin, the same thing. It should be effective as an anti-pseudomonal.
Very good. And another one, do we need to treat the sinuses or focus on the lungs if we're not winning?
That's a great question. I think that for some people, really working on their sinuses is important. I think that if you have challenges with people that have recurrent exacerbations or infections that are problematic and are not treated adequately with oral or intravenous antibiotics, then looking at their sinuses, seeing an otolaryngologist about potentially surgery or doing nebulized nasal antibiotics can be helpful. But that's on a case-by-case basis. We tend to not do surgery as much as other centers because you do know that the surgery is a temporizing thing. Polyps come back, you do need to do recurrent surgeries in some cases, in many cases. So if we can manage it without surgery, that's our preference.
Very good. Another question about duration of intravenous antibiotics for exacerbation. 7, 14, 21, or is it clinical?
So our standard is to do 14 days if you are sick, and we do half in the hospital and half at home. That's our standard practice. Some people stay in the hospital the whole time for various reasons. The new data from STOP2, which is just presented at NACFC, shows that if you're doing well, if you respond rapidly and you have a return to lung function or to baseline fairly quickly, then 10 days is probably adequate, and you don't need to go to 14. And the flip side is true as well. If you go to 14 and you don't see a lot of improvement, going to 21 may not get you any additional benefit. There are clearly people that need to go to 21 days, but I think if you've had, it seems like things are plateauing and not continuing to improve, then doing another week may not be beneficial. So we published data many years ago from the twin and sibling study showing that your lung function should go up substantially in the first 3 to 5 days of IV antibiotics. So when we admit people, we do intravenous or pulmonary function testing when you're admitted, and then we do another set of pulmonary function testing, usually 4 or 5 days in. And if things have not improved significantly, then you have to say something's not right. You know, maybe you need a different antibiotic, maybe they've got ABPA, maybe they've got occult diabetes, something that's not allowing your therapy to be effective. And then change your therapy based on that. If things have gone up, then you can continue with what you're doing. The sort of the change I think we're going to be making moving forward is if you have a big improvement at 5 or 7 days, maybe instead of going 2 weeks, you could go 10 days and see if 10 days is adequate moving forward. I think less is going to be more in this setting in general.
Good. Another question about Stenotrophomonas multifilia. A child is not doing well, only grows Stenotrophomonas multifilia, bronchoscoped, only steno, which was initially sensitive to cotrimoxazole, not doing well in terms of clinical progress. Any words of wisdom?
Yeah, I think Stenotrophomonas certainly can be a pathogen that can be problematic. We have had patients that only grow Stenotrophomonas, and that's clearly a pathogenic bacteria. If we find it in general, if you find it in addition to another bacteria, if we were treating them, we would treat the Stenotrophomonas as well if they were having an exacerbation. So if they grew Pseudomonas, we would do Cipro and trimethoprim sulfa. In someone like you're describing that's resistant to trimethoprim sulfa, ceftazidime can be effective as an antibiotic. You can do inhaled ceftazidime every other month, although I'm reluctant to do that because I think it does lead to resistance of a drug that you may need to use intravenously. Mm-hmm. But those are the main things that we've done, and looked at some of the newer cephalosporins. I think also have some effectiveness against Stenotrophomonas, but it's a difficult problem if they're Bactrim resistant. Minocycline can also be effective in some cases. Yeah. We have done Bactrim suppression, so put people on Bactrim chronically when they get sick frequently with Stenotrophomonas. Again, there's a risk of resistance with that, but that is another strategy.
Very good. You've touched on the NTM, and as somebody said, it's a funny organism. It's the only organism that's named by what it is not, being an non-tuberculous mycobacterium. So you've touched on it to treat or not to treat kind of thing. So basically clinical, radiological, and wait and see. Would that be your approach?
Yeah, we tend to prefer treatment. So if you find it and there's any concern that things are not going well, then we would treat it. If things are really going great and it's not abscessus, we always treat abscessus. If it's Mycobacterium avium and people are doing great, I think we would be willing to watch that one. Or some of the more unusual NTMs that we see, lentivirum and things, we don't necessarily jump in to treat those.
Fantastic.
Peter, I have to say, just to qualify that, there are some centers where the NTM is much more prevalent. So some centers have 30% of their patients have NTM. They are much less, they treat less aggressively. They are much more willing to observe. So it is this is sort of my personal opinion on it. There are other places that are more willing to observe people with NTM.
Very good. One last question, antibiotic resistance in terms of antibiotics choice, bowel cultures, how far should this affect our decision when we treat Pseudomonas aeruginosa exacerbation?
So I start with the antibiotics that they are sensitive to on the panel, but you have to realize that it doesn't always, sensitivity in the lab doesn't always correspond to efficacy when you actually use the drug. So there are several studies that have shown this. So that's why doing the PFTs after a few days to make sure the antibiotics are actually effective is important. If it's not, you're not getting an improvement either in symptoms or lung function, then I would change the antibiotics and even use something that it's resistant to. If you're not getting a benefit, because you may find that in combination with tobramycin, that antibiotic is actually effective at improving symptomatology. There's a lot of interest in not doing sensitivities or doing less sensitivity testing because it's not clearly beneficial in picking antibiotics. And in inhaled antibiotics, where you're getting a very high concentration in the sputum, again, resistance is not as critical because those resistance numbers are based on intravenous therapy or blood levels.
Has there been times that you didn't look at the antibiogram and continued clinically irrespective?
Yes, so if the patient's doing well, then I'll continue with the antibiotic even if it's resistant. And our approach, so if you're admitted for exacerbation, our standard therapy is to do either cefepime or ceftazidime and tobramycin. And we'll start with those typically in most people. If you're resistant to those, then we might start with a different beta-lactam. But even if you are resistant, if it's worked in the past, especially, we would start with that again.
Very good. And I'll take this as the last question. We look for exophilia in our laboratory routinely. What's your view on treatment of exophilia as an amorphous fungi?
You know, that's a very interesting question. There are a lot of these fungi, scedosporums and other, that we find, and I don't know what to do with them. I think that if they're there and your patient is not doing well, then I would treat it. I wouldn't treat it just, if you find it, I wouldn't treat it prophylactically or as an eradication strategy. I think that fungi is very difficult to eradicate, and when you're not sure if it's actually causing a problem, I'd hate to cause resistance in it because it's going to be around for a long time. We've tried, there is some data around the more unusual organisms that does seem to imply that it has a greater impact on lung function than Candida, for example. But the difficulty in treatment makes us wait to make sure it's really, we've done everything else first before we go after those kind of things.
This is great. Thank you very much, Peter. We had huge attendance, and I'd say the interest has been maintained till the very last minute. A lot of questions, but in the interest of time, I suppose we'll stop